again there, listeners and readers and nursing and medical students alike. This is Professor Setterby. Today we dive into the study of medical, surgical, nursing, and orthopedics. We're going to help you go through and take a deep dive of some of the core principles of orthopedic nursing through a creative and interesting tale of a nursing student on a visit on the floor of, well, let's just get into it, on an orthopedic floor. Once again, these stories are meant to help you pick up on some of the core principles in your musculoskeletal unit or whatever unit you're studying while you're kind of falling asleep. It's a passive approach to studying when you really are on your last resort and helping you check that final box for a passive learning modality. Did you get the concepts? Did you get that last little bit? It's your relax app when you have no time to relax because it's nursing school. And I'm just going to help you get that last little bit of knowledge in as you fall asleep. So without further ado, today, or hopefully tonight's topic is the musculoskeletal system. And our tale today is titled The Brave New Ortho Floor Nurse, Bonesia, and the Bones of OrthoLandia, a whimsical musculoskeletal storybook with hidden NCLEX powers. In the Kingdom Hospital of OrthoLandia, a brand new ortho floor nurse named Bonesia hurried down the glowing corridor of Unit 4B, Bones and Joints, her badge shimmering with tiny tibia and femur charms. Today was an extra special day because she would be mentoring a shy student nurse, Tibby, under the watchful eyes of seasoned nurse proctors KneeNa and Humero, and the wise, calm clinical Professor Setterby. Tibby clutched her report sheet like a shield as they approached the first room. Remember, said Professor Setterby kindly, clinical judgment is just a fancy way of saying see clearly, think clearly, act clearly, and we'll practice that with every bone and joint today. Tibby nodded, cheeks pink, and followed Bonesia to their first adventure, the MRI chamber of Magnetica. Their first stop was Radiology Row, where the doors were labeled with runes X-ray, CT, MRI, myelogram. A patient stood anxiously outside the MRI chamber of Magnetica, jangling with bracelets, necklaces, and hair clips. What instructions will you reinforce before this patient goes into MRI? NceLEX asked. Tibby thought about it. Do I let them wear cotton? Avoid citrus? Empty their bladder? Professor gave a tiny smile. Bonesia whispered, Think magnet, Tibby. Oh, Tibby said at last. Because MRI uses a powerful magnet, we must tell the patient to remove all metal. That means jewelry, glasses, hair clips, and anything magnetic. It can become dangerous in the scanner. Exactly, said Setterby. We care about comfort, yes, but safety always comes first. The patient nodded and started taking off their jewelry and trinkets and put them in a safety basket, which Tibby gently collected for them. The cast of the cold fingers. Next on the ortho floor, Bonesia led Tibby to a room where a patient had a fresh cast on the right radius and ulna. "Let's do a neurovascular check," Humero said, leaning on the doorway. Tibby examined carefully. Capillary refill is 5 seconds. The fingers feel cold, and the patient says their hand hurts a little bit. Humero raised an eyebrow. "What's your first intervention going to be?" Tibby's heart began to thump. "Call the charge nurse. I think it's compartment syndrome." Wait, no. I put on a warm compress first. No. It's an emergency. We gotta cut the cast." Bonesia approached her gently and put a steadying hand on her shoulder. "Tibby," he said, "what do we do first?" "Oh, first, I would elevate the right hand to heart level so we can maintain arterial pressure and help circulation. And then we notify the charge nurse." Professor Setterby gently nodded her head. "Perfect. We never ignore cold fingers and cap refill. We elevate, then escalate. We don't cut off the cast independently, and we avoid warm compress because that might worsen the swelling." Tibby wrote all this in her mental scroll. Cold cap refill, if it's more than 3 seconds, elevate, then notify. Got it. The long leg of ORIF. In the next room, a patient had undergone an ORIF of the left tibia and wore a long leg cast. Tibby examined. The left foot is warm and pink. Pedal pulse is present, but a bit weaker than the right. Cap refill is 3 seconds, and there's a tiny 1 centimeter spot of blood on the cast. She frowned. Is this a crisis? Professor Setterby tilted her head. What do those findings actually tell you, Tibby? Tibby wrinkled her brow. The foot is perfused, pulses are present, and a small spot of blood is expected early after surgery. But these are within normal limits. I should document and continue to monitor for any changes, or if there is more blood, or if the patient reports any pain, or if the color changes. Exactly, said Bonesia. Not everything that looks different is dangerous. Some findings simply say, hey, I'm healing. Keep an eye on me. Callus, the bone's secret bridge. Later, that same patient asked Tibby, the doctor said my x-ray shows callus formation. Is that bad? Tibby smiled. Not at all. Callus formation means your body's building a soft bony bridge across your fracture. At first it's fibrous, not fully strong, but over time it hardens into true bone. It's a sign that healing is underway. Like building a bridge after a storm, the patient asked. Exactly, said Tibby. Your bone is an excellent bridge builder. Meloxicam and RA lessons. Down the hallway, a patient with rheumatoid arthritis looked sheepish. I take meloxicam, they said, but if I feel better for a few days, I just stop it. I don't like taking pills when I'm not hurting. Bonesia looked at Tibby. Teaching moment. Tibby sat at the bedside. Meloxicam is an NSAID. That helps control inflammation over time. That helps control the inflammation, and it's safest and most effective if you take it exactly as prescribed, even when you feel okay, unless your provider says to change it. Stopping and starting on your own can actually cause flare-ups and problems. Then Professor Setterby looked at the patient and said, "You should actually treat RA like a smoldering fire. Even when you don't see the flames, you still need to control the heat. There's always fuel lurking behind, ready to start up a spark again." "Oh," said the patient. He nodded. "I guess I'm gonna take it as directed." The Myelogram River and the CT Gate. In radiology row again, Tibby watched as the patient returned from myelogram with a water-soluble dye. "What do you expect in the plan of care now?" NceLEX asked. Bed rest?" "Not flat," Tibby asked. "The head of the bed will be elevated for a period of time to reduce the risk of the procedure headache complications." "Good," NceLEX said. "Let gravity be your helper." At the CT gate, another patient was about to have a contrast CT. A red warning symbol flashed above the chart. "History of severe iodine allergy." Tibby pointed at it. "The delay of CT until the allergy is addressed and the provider makes a safe plan. Contrast allergy is a stop sign, not a speed bump." The CT gate dimmed approvingly. Gout Mountain and the Flaming Great Toe. On Gouty Ridge of OrthoLandia, a traveler grasped at his great toe, grimacing. "Oh, why is this toe so angrily inflamed?" he groaned. Tibby knelt beside him. In gouty arthritis, uric acid crystals build up in the joint, causing painful inflammation, especially in the big toe. "And the food I ate matters?" he asked. "Yes," Tibby said. Foods that are high in purines, like organ meats, certain fish like anchovies, sardines, and some red meats can increase uric acids and make attacks feel more frequent and painful. Part of your care plan is avoiding those foods. Later, with gout patients, Tibby added, teaching should be drinking plenty of fluids, limiting alcohol, and taking gout medication as ordered, especially avoiding those high purine foods. As they walked away, Bonesia whispered, "You just turned purine biochemistry into something your patient actually understands. That's real magic." ESR inflammation and the invisible fire. In the lab consultation alcove, a patient being evaluated for rheumatoid arthritis looked worried. "They said my ESR is high. Does that mean I'm doomed?" Professor Setterby spoke gently. "A high erythrocyte sediment rate tells us there's inflammation present in your body. It doesn't tell us everything, but it helps paint the picture. It's a clue, not a verdict." Tibby added, "We use ESR with your symptoms, exam, and other labs to understand what kind of inflammation we're dealing with, like RA." The patient took a deep breath and then looked a little bit calmer. Osteomyelitis and the draining wound. In another room, a patient held out an arm with a draining wound. "I've osteomyelitis," he said. "A bone infection? Now what?" Tibby donned the appropriate PPE and considered the drain. "Our priority," she said, "is infection control and wound care. We'll use proper sterile technique for dressings to protect others from contact with the drainage and watch closely for signs of worsening infection. You'll likely have strong antibiotics for weeks." Bonesia nodded. "Osteomyelitis doesn't scare us. We respect it, we treat it, we protect everyone else around it." The shadow bone, osteosarcoma. Later in the emergency wing, a 16-year-old boy came in with a pathologic fracture of the left femur and pain on weight bearing without major trauma. Humero leaned close to Tibby. What diagnosis has to be on your mind? Tibby's voice lowered. Those are common findings in osteosarcoma, a malignant bone tumor, especially in teens with long bone and pathologic fractures. Right, said Professor Setterby. We don't diagnose here, but we do know what to suspect and escalate. Kyphosis, lordosis curves of the spine. On the geriatric unit, they met an 82-year-old woman with severe kyphosis and ankylosis. What will you include in her home health care plan? NceLEX asked. Monitor her respiratory status, Tibby answered. Severe kyphosis can limit lung expansion and increase the risk of breathing problems. We'll watch her oxygen and breathing sounds and look for signs of fatigue. In an outpatient clinic, a 20-year-old woman came in with exaggerated lumbar curves. The office said, Tibby, what's that called? Well, that's on the opposite end of the spine, not quite in the middle, but all the way down, closer to the sacral end. That's gotta be low down, lordosis, Tibby said. Am I right? Yes, that's a sway back, Humero said. Tuck that in your mental anatomy book. RA versus OA, the fire and the rust. At the teaching circle, Professor Setterby conjured two glowing joint illustrations. One joint was red, warm, and swollen on both sides of the body. The other looked worn, rough, on mostly one side, like an old hinge. This is how we distinguish between rheumatoid arthritis, otherwise known as RA for short, and osteoarthritis, she said. RA is systemic autoimmune disease. That affects joints systemically. It's driven by inflammation. Osteoarthritis is wear and tear, degeneration of the cartilage. It affects weight-bearing joints, and sometimes just one size. And exercise? Asked Tibby. Yes, and with exercise. So, gentle exercise, Tibby said. Which one is that best for? Well, gentle exercise can decrease stiffness in both RA and OA. It may be hard to convince our patients to start, but it's very good to help reduce stiffness, especially in the mornings. So RA is the red glow, and OA is the one-sided wear and tear, kind of happens with age. That's right, said Professor Setterby. Osteoporosis, bones of glass. In the education room, a 58-year-old woman sat nervously when her tensiometry results came back. Oh, my mother had osteoporosis, she said. I've been menopausal for 5 years. Now they say I have it too. Tibby sat behind her. Risk factors like being female, postmenopausal, having a family history and a smaller frame, smoking, or long-term corticosteroid use all increase the risk of osteoporosis, but knowledge is power. They talked about how bone density naturally decreases after age 50, especially without enough weight-bearing activities and calcium. Well, what can I do now? Asked the woman. You can help slow the process, Tibby answered. That includes consuming calcium-rich foods with vitamin D consumption too, weight-bearing exercises, avoid smoking and excessive alcohol, and be cautious with fall risk prevention activities. Sometimes your provider will also add some supplemental medications. The woman listened carefully to Tibby's explanations and nodded her head slowly. So I'm not helpless, she said. Not at all, said Professor Setterby. Now you're informed and empowered, which is always stronger than fear. Later in the dairy meadow, Tibby pointed out foods high in calcium: milk, peas, some leafy greens. Fortified foods are also always a good thing, so you should learn to read labels in the back of your favorite foods, even if sometimes they're a cheat food. Some of these bars and cereals have been fortified with things that are actually good for you. The osteoarthritis knee and strengthening quest. A 56-year-old patient with knee osteoarthritis limped into the clinic. What strengthening exercises should I do? They asked. Gentle, low-impact exercises are your friend, Tibby said. Things like quadricep strengthening exercises, straight leg raises, and maybe cycling and swimming can strengthen your muscles without pounding on your joints. She explained that osteoarthritis is characterized by joint pain and often worsens with the use of stiffness and rest, decreased flexibility, possible crepitus, and no systemic signs like fever or weight loss. Those are more usually associated with RA. Your goal is to keep moving safely, said Tibby. Rusty hinges seize faster than oiled ones, Bonesia added. Gout teaching and opioid caution. Later, Tibby reviewed discharge instructions with a patient who had gouty arthritis. Your teaching includes avoiding high purine foods, taking medications as ordered, staying hydrated, and avoiding alcohol. Call us if pain worsens or you get fever and chills. In another room, a patient lay drowsy after surgery, and their breathing slowly started to decline. The MAR showed that they had a dose of an opioid agonist, and it was now due. Humero glanced at Tibby. Do you give it? Tibby checked the respirations again and also checked the level of consciousness. If the patient has very low respirations or is overly sedated, we need to withhold the opioid and immediately notify the provider. We don't stack drugs onto slowed breathing. Well reasoned, said Professor Setterby. Pain relief is important, but we do not ever mess with the A or the B and the ABCs. The curse of bed rest. On the long stay unit, an older adult patient lay in bed day after day. What does prolonged bed rest put them at risk for? Bonesia asked. Tibby sighed. Oh, so many things. Let's see. Muscle atrophy, contractures, pressure injuries, venous stasis, pneumonia, increased risk of osteoporosis, and orthostatic hypotension. So what's the antidote? Miss Setterby asked. Oh boy, mobilize when safe, turn regularly, perform range of motion exercises, protect the skin, and get them upright as soon as possible, Tibby replied. In other words, don't let the bed steal their strength. Heavy loads and abduction dances. In the rehab gym, a worker who spent years lifting heavy loads with the right arm showed off a bulging bicep. What does daily heavy loads on one arm cause? NceLEX asked. Hypertrophy of those muscles, Tibby answered. They grow larger and stronger with consistent use. Nearby, a dancer lifted her leg out to one side. What movement is that? Humero asked. Oh, when it goes away from the body, it's abduction, Tibby replied. Like alien abduction. Take me away. Movement away from the body is abduction. That's right, the dancer repeated. Abduction. I'm being abducted. Uncompartmental knees. What's that word again? Uncompartmental knees, hip replacements, and phantom feet. In another ward, a patient awaited an uncompartmental knee replacement. What's the big advantage of the partial knee replacement? Bonesia asked Tibby. It usually means less tissue disruption and faster recovery, especially when the compartment of the knee is diseased, Bonesia told her. The rest of the joint is as natural as possible. On the post-op floor, the patient had a right below the knee amputation, and Bonesia showed Tibby the stump. I keep falling on my right foot, the patient told the nurses. Am I losing it? Tibby looked at the patient and said, I think that's called phantom pain. This is pretty normal. Your brain is remembering your limb pain. Your nerves are signaling to your brain that it's still there. There's a medication called gabapentin. We can ask the doctor to place an order for you. Oh, yes, please do. It's still very painful, even though it's no longer there. In the next room, a patient with bipolar hip replacement needed turning every 2 hours. How do we position their legs? Tibby asked. We keep legs in abduction, never ever crossed, Bonesia said. We avoid flexing the hip more than about 90 degrees. We do this to avoid internal rotation and prevent dislocation. Warfarin was also hanging in a bag on the IV pole for the hip replacement. Why warfarin? Tibby asked. To prevent deep vein thrombosis. Replacement plus immobility equals clot risk. Tibby then thought hip replacement patients do quadriceps setting exercises, tightening the thigh muscles with the legs straight, holding the hips to stabilize strength. For knee replacement, she emphasized strengthening the unaffected leg and straight raises so the leg could bear most post-op exercises. The patient watched her demonstration impressed. Traction and the fat embolism storm. In pre-op, a 68-year-old with an intertrochanteric hip fracture laid in bed with ropes and pulleys attached to the leg. This is Buck's traction, Tibby explained. It's the main purpose, so you can maintain your hip alignment, but also reduce muscle spasm. It really helps relieve pain after surgery. Then all of a sudden, out of nowhere, glitter droplets of fat appeared in the hallway. Oh no, it's a fat embolism. 48 hours after a femur fracture, the patient suddenly had a pulse of 110, respirations of 25 that were labored, and crackles in both lungs. Tibby's eyes widened. These are classic signs of a fat embolism and a long bone fracture. What's going to be your priority intervention? Professor Setterby asked. Administer high-flow oxygen. I have to follow the ABCs. The respiratory system comes first. This is an emergency. The storm began to calm. The boy with one leg and the power of words. At the very end of the day, Tibby and Bonesia visited a 14-year-old boy scheduled for a leg amputation. He stared at the floor. What in the world am I going to do with one leg? Tibby sat at eye level and spoke softly. You're going to learn new ways to move, skills and strengths you didn't know you had, she said. You'll still be you, with hopes, friends, talents, and we'll support you through rehab, prosthetics, and everything in between. You're not alone in this. The boy blinked, eyes brimming, but a smile appeared. You really think I can do it? I don't think it, Tibby said. I know it. Professor Setterby watched in the hallway as the nursing student performed excellent therapeutic communication with her patient. This is a great example of the NANDA, of showing excellent communication of body adjustment. She was very proud of Tibby. This is the art of nursing. As the glowing OrthoLandia sky shifted from day to twilight, Bonesia, Tibby, KneeNa, Humero, and Professor Setterby all walked the corridor from their 12-hour shift. You met MRI magnets, ET allergies, casts, ORAFs, RAOA, gout, osteoporosis, traction, fat embolisms, amputations, hip and knee replacements, and more, Professor Setterby said. But more importantly, you learned how to turn each fact into a safe action and human comfort. Tibby smiled, exhausted, but glowing and beaming with confidence. Bones and joints may creak and crack, she said, but nursing judgment holds the kingdom together. And OrthoLandia, for one more night, rested safe, well in educators' hands. Sleep well, nurses, because tonight you enforced your skills. Another lesson, another creak, another crack. Hopefully, this reinforced your nursing knowledge. Stay tuned for more nursing systems, more repetition. I hope you learned something tonight. Good night, nurses.